very good morning from INEDSYS and good evening to those in the other side of the world. We have a fantastic session today. We have Professor Salvatore Piano, who is an associate professor of medicine and consultant hepatologist at the University and Hospital of Padova, Italy. His main research interests are pathophysiology and treatment of complications of cirrhosis, ascites, acute kidney injury, hepatorenal syndrome, bacterial infections, and acute-on-chronic liver failure. His research has been supported by the European Commission, Italian Ministry of Health, Italian Ministry of University and Research, and EASL. He is a recipient of the EASL Emerging Liver Leader Award and the UEZ Rising Star Award. He is Associate Editor of JHEP Reports, Liver Transplantation, and Clinical and Molecular Hepatology, and Editorial Board Member of Journal of Hepatology. With that introduction, I would like to hand it over to Dr. Salvatore Piano, who's going to talk today on management of AKI in cirrhosis, a very, very important topic for all of us. Over to you.
Thank you, Sanjaya. Hello, everybody. And thank you very much for inviting me to give this talk. So I will talk about management of AKI. This is the outline of my talk. So I will start discussing the current guidelines about diagnosis and treatment of AKI. And then in the last part of the talk, I will discuss some controversial issues and some future strategies that may help improving the management of these patients. But let me start saying that we are talking about AKI in cirrhosis. Oh, sorry, it's not going well. Okay, sorry. So we are talking about AKI in cirrhosis because this is a very common complications. As you can see on your left side, almost 50% of patients hospitalized for an acute decompensation of cirrhosis develop AKI during the hospitalization, and those developing AKI have a fourfold increase in hospital mortality rate. And the reason why AKI is so common in these patients is strongly related to the pathophysiology of cirrhosis. Indeed, those with cirrhosis and portal hypertension have an increased gut bacterial translocation because of increased permeability in the gut. This is leading to systemic inflammation, and systemic inflammation in the splanchnic arterial circulation causes the release of nitric oxide, carbon monoxide, and other vasodilators, causing a splanchnic arterial vasodilation that can be also caused directly by portal hypertension. Splanchnic arterial vasodilation causes a reduction of effective circulating volume. Then in the early phase of the disease is counterbalanced by an activation of endogenous vasoconstrictor systems, catecholamines and renin-angiotensin-aldosterone system that try to increase cardiac output and reduce the splanchnic arterial vasodilation. However, in the most advanced stages of the disease, when systemic inflammation and other mechanisms cause also cardiac dysfunction and cirrhotic cardiomyopathy, there is a further reduction of effective circulating volume that causes a reduction in renal blood flow. And even the activation of endogenous vasoconstrictor system, that is a defensive mechanism at the beginning, can contribute to the reduction of renal blood flow through severe renal vasoconstriction that is causing a reduction of renal blood flow. In addition, in these patients, there are also other mechanisms that can cause AKI. In fact, systemic inflammation per se may cause an oxidative stress and metabolic alteration, causing a direct damage to the kidney as it occurs during sepsis. The excess in circulating bile acids can cause cholemic nephropathy, and in some patients with tense ascites, the increase in abdominal pressure can further contribute to the reduction of renal blood flow, causing AKI. And of course, in this pathophysiology scheme, any events that can increase any one of these factors can precipitate AKI. This is the case of infections or alcohol-associated hepatitis that increase systemic inflammation. It's the case of vasodilators that can worsen splanchnic arterial vasodilation. is the case of any events that further reduce the effective circulating volume, such as an overdose of diuretics, gastrointestinal bleeding, diarrhea or large volume paracentesis, or the use of NSAIDs that affect the ability of autoregulation of the kidney. Let's say that when we talk about AKI and cirrhosis, we always think to hepatorenal syndrome, that is just one specific phenotype of AKI occurring in patients with cirrhosis that is predominantly functional. It occurs in patients with cirrhosis and ascites, has features of prerenal AKI, but do not improve after plasma volume expansion, and it develops as a consequence of severe reduction of effective circulating volume, extreme splanchnic arterial vasodilation, and relative reduction in cardiac output that cause a massive hyperactivation of endogenous vasoconstrictor system that cause the severe renal vasoconstriction. And it is important to note that hepatorenal syndrome is not that common. Okay, less than 20% of patients with cirrhosis and AKI develop HRS as a phenotype. In fact, most of them have an hypovolemic AKI that respond to fluid resuscitation. That said, it's very important to recognize patients that have HRS-AKI for two reasons. The first one is that one of the phenotypes of AKI with the worst prognosis, as you can see in this graph. And the second one is that it has a specific treatment that is vasoconstrictors and albumin, and we will talk about that later on. So let's start with the definition, okay? So we define acute kidney injury in cirrhosis as we do in general population. We define AKI in patients that experience an increase in serum creatinine equal or higher than 0.3 milligram DL within 48 hours, or that have a relative increase equal or higher than 50% from baseline in 1 week, or in those in whom there is a reduction of urine output below 0.5 ml per kilogram per hour for more than 6 hours. And this criteria is usually applied in ICU or when we can monitor adequately urinary output. So according to the relative increase in serum creatinine, we can stage acute kidney injury in 3 different stages. Stage 1, when the increase in serum creatinine is below twofold from baseline. Stage 2, when the increase in serum creatinine is higher than twofold but less than threefold from baseline. And stage 3, when the increase in serum creatinine is more than threefold from baseline or reach a final level above 4 milligram DL, or in case the patients need for renal replacement therapy. Stage 1 AKI is definitely the most common stage in these patients, 50 to 60%. And there are several studies that have actually shown that we can subclassify patients with stage 1 AKI in 2 groups with different prognosis and characteristics. Stage 1A, serum creatinine below 1.5 milligram DL. Stage 1B, AKI with serum creatinine equal or higher than 1.5 milligram DL. And the reason of this subclassification is that there are at least 4 studies that have included more than 3,000 patients with cirrhosis that consistently showed that patients with AKI stage 1B have a worse prognosis than those with stage 1A. Of course, the worst prognosis is in those with stage 2 or stage 3 AKI. So after having recognized the AKI in patients with cirrhosis, the first step is usually to identify and treat the precipitating factors. I already mentioned that in the pathophysiology scheme. I just want to remind you that the most common are for sure bacterial infections. We should also check for the use of potential nephrotoxic drugs such as diuretic overdose, of use of non-steroidal anti-inflammatory agents. And I just want to remind you that if we systematically look at precipitating factors, we will be able to identify and potentially treat precipitating factors of AKI in more than 90% of patients. So it is very important to systematically look for precipitating events, and those most common are for sure volume loss and bacterial infections. Then the next step of management is for sure volume resuscitation with albumin or crystalloids according to the clinical scenario. And then for those that are not improving after the initial measure, that usually the differential diagnosis is between parenchymal AKI, most of the time acute tubular necrosis versus hepatorenal syndrome. And in this case, usually we need to also apply urinalysis to find the specific features of hepatorenal syndrome versus parenchymal nephropathy. So the EASL guidelines suggest a specific algorithm for the management of patients with cirrhosis and AKI according to the initial stage. So we have two different boxes, one AKI stage 1A on your left side, one on initial AKI stage equal or higher than 1B. Okay, so for patients with AKI stage 1A, they suggest the close monitoring of renal function and diuresis, the identification and removal of risk factors, the tapering and withdrawal of diuretics, the plasma volume expansion according to the clinical scenario when indicated, and identification and treatment of infections. And the reason why these measures are considered sufficient for this group of patients is because we will be able to treat more than 80% of the phenotypes of AKI that usually occur in AKI stage 1A, that in this study were defined as pre-renal, that was hypovolemic, therefore they are responding to volume expansion, or miscellaneous, but actually in this study we defined the miscellaneous AKI induced by bacterial infections or by nephrotoxic drugs. Very few patients have ATN or will develop HRS. So if the patients have a resolution of AKI, okay, we are happy. We still will close them. We will follow up them closely because these patients have a worse prognosis than those patients that have never experienced an AKI. While for those that progress to AKI stage 1B, 2, or 3, we should apply measures that should be applied since the beginning in this group of patients, that is withdrawal of diuretics, and plasma volume expansion with albumin, 1 gram per kilogram of body weight for 2 days. Then, if the patient has a response with a resolution of AKI or at least a reduction in stage, okay, we are happy. In case of non-response, we should check for criteria of hepatorenal syndrome, and in case the patient does not meet the criteria of HRS, we should treat the specific AKI phenotypes. Most of the time, the phenotypes is acute tubular necrosis, therefore the management is supportive, while more rare case may due to IgA nephropathy or even more rarely glomerulonephritis. If the patients meet the criteria of hepatorenal syndrome, the treatment includes the use of vasoconstrictors and albumin. And I have to say that although this algorithm of management was actually included in guidelines, the EASL guidelines, most of the procedures that are suggested are not based on evidence or randomized clinical trial, but most of them are based on expert opinion. And that said, I have to say that we have now some evidence suggesting that managing patients with AKI according to this algorithm can actually potentially improve their outcome. This is a study, a pre-post study, that evaluated the management of patients with AKI before or after the application of EASL algorithm for day management. And you can see that in the contemporary cohort managed according to this algorithm, there was a higher rate of resolution of AKI and a lower rate of 90-day mortality. And this means that when each time that we want to change the management of this patient, we should actually be very careful because this algorithm actually proved to be effective. Let's say that we started to have some evidence. For example, it's years that we suggest to taper withdraw or withdraw diuretics in this patient that most of the time have ascites, have a peripheral edema. And now we have also evidence supporting this strategy. This is a sub-analysis of the International Club of Ascites Global AKI study, showing that patients with AKI in which the management of diuretics was done according to the EASL International Club of Ascites algorithm, the rate of resolution of AKI was significantly higher than the group that did not apply this algorithm. And after adjusting for confounders, the tapering and withdrawal of diuretic was associated with an 18% risk reduction in AKI non-resolution. So now let me move to diagnostic criteria of HRS. So at this stage, I will mainly refer to the International Club of Ascites criteria published 10 years ago. And the reason is that most of the evidence that we have nowadays about the use of vasoconstrictors and albumin in patients with cirrhosis applied this criteria for the definition of HRS-AKI. Then in the second part of this talk, you will see that now we had a new definition with some pros and some cons. So we define HRS-AKI in patients with cirrhosis and ascites, the type AKI that have no improvement of serum creatinine after at least 2 days of diuretic withdrawal and plasma volume expansion with albumin, that have no signs of shock, no recent use of nephrotoxic drugs, and they have no macroscopic signs of parenchymal kidney disease indicated by a significant proteinuria, microhematuria, or abnormal renal ultrasonography. Regarding vasoconstrictors and albumin, the use of terlipressin plus albumin is the first-line treatment for these patients. The second-line treatment in countries where terlipressin is not available or where in case in which the cost is not affordable, noradrenaline plus albumin is an alternative. And then the third line of treatment that you will see is actually reserved only to a small group of patients is midodrine plus octreotide plus albumin. Now, the rationale of the use of terlipressin plus albumin is because in the pathophysiological scheme of HRS, we use terlipressin to counteract the splanchnic arterial vasodilation and to reduce portal pressure. And on the other hand, we use an albumin to counteract the reduction of effective circulating volume, and also because albumin, and I will show you some data later on, can counteract cardiac dysfunction in patients with cirrhosis and ascites. So in this slide, I summarized the results of the 3 randomized controlled trial that compared terlipressin plus albumin versus placebo plus albumin in the treatment of HRS-AKI. And as you can see, they all consistently show that terlipressin is significantly more effective than placebo in treating patients with HRS-AKI. And I have to say that in all this study, terlipressin was used as intravenous boluses every 4 or 6 hours. That is not the best way to use this drug from a pharmacokinetic, pharmacodynamic point of view, because this is a drug with a very short half-life. And if we look at this very old study that investigated the effect of terlipressin on hepatic venous pressure gradient, you can see that after a single bolus of terlipressin of 1 milligram, there is a rapid and significant reduction of HVPG, but this effect lasts 3 hours, and at 4 hours, there is no significant difference versus placebo. And this means that in clinical practice, when we use terlipressin as intravenous boluses every 4 or 6 hours, we are unable to have an hemodynamic effect that lasts all the 24 hours. Okay, the alternative is to increase the dose of the drug, but this may actually cause an increase of adverse events. And or an alternative strategy may be to use a continuous infusion of terlipressin that may help in maintaining more stable effect, more stable hemodynamic effect of the drugs. And according to this background, we designed the randomized controlled trial comparing the two intravenous route, continuous infusion versus boluses. And as you can see, there was no significant difference in terms of response, full response of partial and full response together between the two arms. However, patients randomized to receive continuous infusion achieved a resolution of HRS-AKI with a lower dose of terlipressin than intravenous boluses, and this translates into a significant reduction in global adverse events and serious adverse events in continuous infusion group than intravenous boluses group. And this is the reason why, at least in Europe, the EMA suggested, that is like the FDA Europe, suggested the use of continuous infusion for these patients. I know that for the United States, it's not that easy, but these are the data, okay? So talking about adverse event, terlipressin is a very strong and powerful vasoconstrictor that may have some side effect, such as peripheral ischemia or acrocyanosis. It may induce myocardial ischemia and therefore should be avoided in patients with coronary heart disease, because diarrhea or abdominal pain that is usually can be easily managed. But I will discuss more in detail about the issue of respiratory failure and pulmonary edema that was an issue raised by the confirmed trial. Okay, so actually, you know, these are the results of the confirmed trial that show that patients randomized to receive terlipressin had a significantly higher rate of respiratory failure than those receiving placebo. Okay, and this actually caused a black box warning about the FDA about the risk of these side effects and the restriction of use in patients that have less risk of respiratory failure. I have to say that in this side of the world, in Europe, we were quite surprised by this result of respiratory failure, because we are using terlipressin since 15 to 20 years. And I just want to show you what is at least my interpretation. So in confirmed trial, before receiving terlipressin, the patients received a higher dose of albumin. The median dose of albumin was 50% higher than the maximum dose that will be recommended by the guidelines before starting vasoconstrictors and albumin. So that the albumin concentration was normalized. I have never seen a patient with hepatorenal syndrome with normal serum albumin concentration. And to me, what happened in the trial is that in patients with cirrhosis that have an increased venous compliance, the infusion of albumin caused an increase of intravascular volume. Then after the injection of terlipressin, this caused a reduction of venous compliance with an increase in preload effective volume, and of course we expected an increase in afterload, and there was an increase in systemic vascular resistance. And in a normal heart, this may actually result in an increase of blood pressure and improvement renal perfusion and renal function, but in an impaired heart, this would have been caused a volume overload and therefore pulmonary edema. And this hypothesis has also been recently confirmed by a study performed in Chandigarh, showing that in patients with cirrhosis and hepatorenal syndrome that had cirrhosis cardiomyopathy had an increased rate of pulmonary edema than those without cirrhosis cardiomyopathy, and none of patients without cirrhosis cardiomyopathy actually developed respiratory failure following the treatment with terlipressin. That said, the authors of the confirmed trial, Florence Fong and colleagues, tried to explore in their cohort a subgroup of patients that had a significantly higher risk of respiratory failure. And what they found was that in patients with ACLF grade 3, therefore with 3 or more organ failures, the incidence of respiratory failure and of mortality for respiratory failure was significantly higher than those observed in the placebo arm. And this is the reason why the FDA and also the EMA suggest to a restriction of the use of Terlipressin in patients with ACLF grade 3, in which the risk may be higher than the potential benefit. I want to also say that actually we should expect a very low efficacy of Terlipressin in patients with ACLF grade 3 and hepatorenal syndrome. This is a study we performed in the CLIF consortium some years ago, showing that higher the grade of ACLF, lower the probability of response to Terlipressin and albumin for each baseline value of serum creatinine at which the treatment is initiated. And what is therefore anyway is poorly effective in ACLF grade 3, but what is more important to me is the graph on your right side showing the 90-day mortality according to response. And as you can see, in patients with ACLF grade 3, there is no significant difference in mortality rate between responders and non-responder to Terlipressin and albumin. There is only a very short benefit at 30 days that may be important for those that are potential transplant candidates, but for most of the patients, this treatment probably may be futile in case they are not potential transplant candidates, and probably their use should be discussed case by case because it may be futile. What about the comparator? Okay, comparison between noradrenaline versus Terlipressin HRS-AKI. Most of the study in the field have been performed in India. Some of them on your left side show that the rate of resolution of HRS was similar between noradrenaline and Terlipressin. More recent data in a subgroup of patients with HRS-AKI and ACLF according to APAS criteria show that Terlipressin is more effective than noradrenaline in treating HRS-AKI. I mean, my take-home message is that Terlipressin is still the first choice, but if you do not have access to Terlipressin or the patient cannot afford the cost, noradrenaline is an alternative, okay? Regarding midodrine and octreotide, these are the results of a multicenter randomized controlled trial in Italy, showing that Terlipressin is significantly more effective than midodrine and octreotide in treating HRS-AKI. The rate of response was really disappointing in midodrine and octreotide group, and therefore for me the take-home message is that midodrine and octreotide nowadays should be reserved only to patients that have contraindication to most powerful vasoconstrictors, for example, a patient with coronary heart disease, okay? What I recommend is not using midodrine plus octreotide before treating the patient with Terlipressin, because losing this time may actually jeopardize the probability of resolution with a more powerful vasoconstrictors. The resolution of HRS is not just cosmetic or renal function, okay? So the patients that respond have a significantly higher probability of survival than non-responders. However, if we compare these results with those achieved with liver transplantation, there is no story. So liver transplantation is the best treatment for patients with HRS-AKI. However, on clinical ground, it is likely that a patient will be treated with vasoconstrictors and albumin and then eventually be transplanted, because these treatments are not mutually exclusive. And what also occurs is that if a patient is treated with Terlipressin and albumin and it achieves response before liver transplantation, this turns in benefit after liver transplant. In fact, the incidence of post-transplant chronic kidney disease is significantly lower in responders than non-responders, and even after adjusting for several confounders such as age, diabetes, AKI post-transplant, or the MELD score at the time of transplantation, non-responders still have an increased risk of chronic kidney disease after liver transplant, while responders have no significantly higher risk versus control without HRS before liver transplantation. And this outcome, chronic kidney disease, is quite important after liver transplantation because we know that in patients that receive a liver transplant and develop chronic kidney disease, each ml of GFR that is below 60 ml per minute, that is the threshold for defining CKD, is associated with an exponential risk of death in this patient. Therefore, preventing this outcome is important. The other issue is what to do in patients that do not respond to terlipressin and albumin and meet criteria for renal replacement therapy. And in this regards, it is very important if the patient is a liver transplant candidate or a potential liver transplant candidate, because in that case, the use of renal replacement therapy as a bridge to transplant is a good strategy. Okay, mortality rate is about 40% at 6 months, but for those that are not listed for liver transplantation, mortality rate exceed 80%. Therefore, it is likely that for the majority of these patients, renal replacement therapy is probably futile and should be decided case by case. Now, let me move to the last part that is shorter about the controversial issues and the future strategies. The area of controversy started with the change in the definition of HRS-AKI, which was proposed by the consensus between the Acute Disease Quality Initiative and the International Club of Ascites, so nephrologists and hepatologists together, that changed this old definition with this new one. So we still have cirrhosis with ascites, acute kidney injury. There was a statement of absence of improvement of serum creatinine and urinary output within 24 hours of volume resuscitation. Therefore, there was a reduction from 48 hours to 24 hours. And there was also a strong statement we recommend against systematic administration of albumin for 48 hours as a requisite for the diagnosis of HRS-AKI. And the rationale for this was to try to avoid volume overload, okay, and to anticipate the treatment with vasoconstrictors and albumin. However, here there are two issues. The first one is what is the alternative to albumin for a patient with cirrhosis, ascites, and peripheral edema? Because we know from a very old study published 40 years ago, but this is just one. There are several that were done in that period showing that patients with cirrhosis have an impaired natriuresis after saline loading. Therefore, this means that if we are using crystalloids or saline, it is likely that this will lead to a further worsening of sodium and water retention in the interstitial space with potential problem. Therefore, the alternative, what is cornstarch, have been banned for any indication, okay? But I just want to show you that albumin may have other benefit in addition to increased natriuresis that have been shown in several studies. So albumin, but not hydroxyethyl starch in patients with SBP is able to increase the stroke work index, that is an index on cardiac contractility, and to reduce the plasma renin activities, that is one of the mechanisms leading to hepatorenal syndrome. In addition, I talked a lot about cirrhotic cardiomyopathy. This is an experimental study in which we evaluated the cardiac contractility in cirrhotic rats ex vivo using a Langendorf system and increased the concentration of isoproterenol. We, as expected, the cirrhotic rats had a lower cardiac contractility because of induced cirrhotic cardiomyopathy. But when we administered albumin at the dose that is provided for SBP before the sacrifice, the cardiac contractility was normalized, and this effect was not reached with hydroxyethyl starch, suggesting that there are some non-oncotic properties of the molecules that can actually improve cardiac contractility. And what we found was that this effect were mediated by a reduction in the expression of TNF-alpha and inflammatory cytokines in the cardiomyocytes of rats. It is the right column. And we also showed that the heart of cirrhotic rats that received albumin before the sacrifice had a lower expression of inducible nitric oxide. And this is important because inducible nitric oxide that is triggered by TNF-alpha produce nitric oxide that has a negative inotropic effect on the heart. So for me, albumin is still the plasma expander of choice for these patients. So what about the reduction of plasma volume expansion at 24 hours? So after the publication of this consensus, there were two studies that explored the effect of shortening the albumin challenge from 48 hours to 24 hours in patients with cirrhosis, ascites, and AKI. And what they found was that among patients that achieved a response at 48 hours, only 60% had already a response at 24 hours. This was consistent in these two studies. And they concluded that if we anticipate the assessment of response at 24 hours, it is likely that we will overdiagnose HRS-AKI and we will overtreat patients with vasoconstrictors. Okay, I did a simple simulation starting from this study and using the data of the two studies that I showed before, and this would lead to an increase from 17% of patients with HRS-AKI to 40% of patients with HRS-AKI. And you can imagine this the issue. In fact, after the publication of this data, there was an expert opinion that suggested that until further data become available, we recommend following the EASL algorithm, particularly regarding the use of 48-hour albumin infusion and establish a diagnostic criteria. Okay, so nowadays it is good to do so. However, I want to highlight that we need to define the criteria of response at 24 hours because looking at the global AKI data, we found that in patients that have no response after 48 hours, the cumulative fluid volume received is associated with an increased risk of 28-day mortality and of respiratory failure, while it doesn't matter in those that respond to AKI. Therefore, too much fluid is probably to be avoided, and we will work in the next period to avoid, to identify different criteria. And, the excess of fluid volume and negative effects in patients with AKI is quite well known, So we know that if we cause fluid overload, this will lead to increasing central venous pressure, increasing kidney afterload, kidney congestion, and AKI. And this is quite well known in intensive care unit or among cardiologists. We study showing that with an increase in central venous pressure, there is a drop in glomerular filtration rate when the central venous pressure exceeds 12 millimeters of mercury. Therefore, let's say that we cannot monitor central venous pressure in all patients with cirrhosis and AKI. We need to find alternative strategy to adequately assess the fluid volume. And one strategy that is raising attention is for sure point-of-care ultrasonography. With the measurement of inferior vena cava diameters at the end of expiration and inferior vena cava collapsibility index. Okay, so we have some data suggesting that the use of this measure is accurate because there is a direct correlation between central venous pressure and the inferior vena cava diameter, and an inverse correlation between the central venous pressure and inferior vena cava collapsibility index, so that 95% of patients with an inferior vena cava above 2.1 centimeters and an inferior vena cava collapsibility index below 50% and a central venous pressure above 10 millimeters of mercury, and therefore had no volume depletion. And there is a study that was just published 2 weeks ago in Hepatology by the Chandigarh group that is working a lot on POCUS that actually applied an algorithm of management of AKI, which was based on point-of-care ultrasonography of inferior vena cava, and they also added the velocity time integral of to as as a measurement of stroke volume, okay? And they are not going into detail, but according to their parameters, they classify the patients in hypovolemic, euvolemic, or hypervolemic. And what they found is that 80% of patients were hypovolemic at time zero, 11% euvolemic, less than 10% hypervolemic. Those with hypovolemia or euvolemia were treated with plasma volume expansion with albumin, while those with hypervolemia were treated with diuretics. And of course, they promoted these strategies for the personalized management of this patient. So, I mean, I like it a lot of this paper. I think that those patients that may benefit most from the application of this algorithm are the subgroup of patients with hypervolemia, okay, in which the plasma volume expansion will be actually potentially dangerous. But if I make a question, are we ready to use POCUS to guide volume expansion in patients with cirrhosis and AKI? The first question is, but does POCUS modify clinical assessment? I just want to show you a case that occurred to me like 10 days ago. We had admitted a 75-year-old male with decompensated cirrhosis and ascites and history of COPD. He was admitted to the hospital for pneumonia and AKI stage 1, and my resident said, okay, Dr. Piano, let's see these patients. I want to do POCUS to assess, the volume status. I say, okay, you can do POCUS, but look at the jugular vein. These patients have jugular vein turgor. I'm quite sure that if you do POCUS, you will see that this patient is volume overloaded, and it was confirmed by POCUS, okay? So we still do not have the evidence that POCUS lead to improved clinical outcome, and this should be explored in randomized controlled trial. Then there is another issue to me. If we can fully rely on POCUS when reassessing volume status after plasma volume expansion. And this question was raised by this study. That is another study in which the Bern group used the POCUS of inferior vena cava following intravascular volume assessment during intravenous albumin infusion. Most of the patients included in this study actually received albumin after large volume pars, and that is a well-established indication. And what they found after serial POCUS is that more than 50% of patients satisfied the criteria of potential volume overload, and more than 20% had criteria of severe intravascular volume overload. That to me, it was impressive because these patients are doing the paracentesis and then they are going at home. But what is impressive to me is that none of these patients, even those with severe intravascular volume overload, developed clinical signs of volume overload. The incidence of AKI was lower in those with volume overload. Mortality was lower in those with volume overload. Therefore, I'm not that sure that these procedures actually identified patients with volume overload. Therefore, I think that this POCUS has really strong potential, but we need more evidence. Now, last part, very brief, the updated diagnostic criteria of HRS-AKI suggests that we may rule in HRS in absence of strong evidence for an alternative explanation as the primary cause of AKI, and that HRS may also occur in patients of some degree of tubular injury, proteinuria, or pre-existing chronic kidney disease. And I think the latter definition is very important because nowadays the rate of comorbidity in our patient with cirrhosis and AKI is really important. Okay, you can see that more than 1/3 of patients have arterial hypertension or diabetes, 1 out of 4 had muscle D, 16% have CKD. Therefore, we need to identify criteria that may actually rule in HRS in this subgroup of patients. But to me, the main issue is what is a strong evidence for an alternative explanation as the primary cause of AKI? Because if we do not define what is an alternative explanation, the issue is that in the next future, there will be an exacerbation of what is already happening today. That means that patients that have no HRS-AKI are treated with Terlipressin. Okay, this is still a sub-analysis of the global AKI study investigating the use of Terlipressin in patients with cirrhosis and AKI. And as you can see, just 50% of patients receiving Terlipressin and actually a final diagnosis of HRS. And what is interesting to me is that those patients with ATN actually had a quite lower response in terms of resolution of AKI and had a significantly higher risk of mortality. Therefore, we really need to define very well when there is no strong alternative. Okay, we can try to classify patients according to the different characteristics. For example, those with ATN AKI, because usually, as I said before, the differential diagnosis is those that don't respond to fluid expansion is between HRS and ATN. Okay, so in ATN, usually patients have received a shock, have received a nephrotoxic drug or a shock. There is a difference in urinary sodium excretion with avid sodium retention in HRS-AKI, while inability to reabsorb sodium and concentrate the urine in ATN-AKI, while the urine sediment may show granular cast or renal tubular epithelial cell in ATN-AKI, while it is usually normal in HRS-AKI. And as you can see, if we do not define clearly what is an alternative cause of AKI, there will be an imbalance between the diagnosis of HRS-AKI according to the background knowledge of the physicians, but also on the ability of the laboratory to measure some urinary biomarker. Okay, now we'll talk a little bit more in detail about some urinary biomarkers such as NGAL and interleukin-18. This is an nephron with different old and new biomarkers and their changes in patients that have tubular damage. And you can see that we have alpha, KIM1, interleukin-18, and NGAL, okay? All of them increase in patients with tubular damage. And there are several studies showing that actually NGAL and interleukin-18 are the two biomarkers with the highest discrimination ability between HRS-AKI and ATN-AKI, and they were also able to predict other outcomes such as mortality or development of ACLF or progression of AKI in the case of NGAL. I show you some data about NGAL because it's the one, this is the biomarker that have been most investigated in these patients. Okay, these are two studies from the Barcelona group showing that patients with cirrhosis, AKI, and ATN had a significantly higher value of NGAL than those with HRS-AKI. Okay, this was based on frozen samples. This was prospective on actual samples. And as you can see, the data were consistent. This is another study from our group, still incorporating NGAL in clinical practice. And as you can see, similar results to the Barcelona team. In patients with ATN, there was a significantly higher value of NGAL, very high discrimination ability, about 0.85. And what we found was that patients that had a threshold of NGAL above 220 nanogram per milliliter had 90% sensitivity and an 81% specificity of having ATN. Okay. In addition, we also show that the NGAL, this biomarker, can also be helpful in predicting the response to terlipressin and albumin in those satisfying the criteria of HRS. Okay, here you can see that those patients that have urinary NGAL equal or higher than 220 nanogram per liter had a resolution of HRS in just 1/3 of cases versus 70% in those with NGAL below this threshold. And these data have also been confirmed using the samples collected in the PREDICT study and the ACLARA study. These data have not yet been published extensively, but presented in the EASL meeting a year ago. And as you can see, patients with HRS-AKI that experience no renal recovery had had a significantly higher value of NGAL and albumin in the urine than those who achieved renal recovery. And this data about biomarker also suggests that probably our way to classify AKI in, in specific boxes probably is incorrect. There is more a continuous between a volume responsive of AKI that, if not treated promptly, can progress to HRS-AKI, that if not treated promptly can evolve to an ischemic acute tubular necrosis. And of course, in the setting of HRS-AKI, the urinary biomarker or tubular main damage can identify patients that are in this phase with very few tubular injury that have higher probability of resolution with vasoconstrictors and albumin versus a group of patients that have a higher rate of tubular injury and that are less likely to respond to vasoconstrictors and albumin. So in summary, this is my last slide. Acute kidney injury is a common and life-threatening complication of cirrhosis. The early management of AKI include removal of risk factors, tapering and withdrawal of diuretics, and restoration of volume status. In patients with HRS-AKI, the combination of Terlipressin and albumin is the first-line treatment, but should be used with caution in patients with ACLF grade 3, in which the risk may outweigh the benefit. The use of Terlipressin as continuous infusion is usually better tolerated. In patients with HRS-AKI, never forget the liver transplant is the best treatment, and all patients should be evaluated for liver transplantation. So regarding the future, I think that until new data become available, it is reasonable to use the EASL International Club of Ascites algorithm for the management of AKI and cirrhosis, but I'm pretty confident that in the future, integrating POCUS into daily clinical practice and use of biomarker of tubular damage may improve the management of AKI by enabling a more precise and individualized treatment. Thank you very much for your attention.
Thank you, Dr. Piano. That was a fantastic talk. I'm really learned a lot today. We have several international dignitaries, pretty well-known hepatologists and gastroenterologists from around the world today. And very proud to say that. So we'll have some great discussions. Before I start opening for some questions and a question-answer session, let me ask one question. In your talk, you mentioned that liver transplantation is the best treatment for HRS-AKI. Also, you mentioned Terlipressin is better than midodrine plus octreotide. You convincingly shown that. One of the issues that we face, or challenge that we face, is these are the patients who would like to most likely benefit with a transplant. Now, and when you treat this patient with Terlipressin, the MEL drops, and it's kind of a MEL purgatory. So weighing the risk and benefits, if it's a living donor transplantation, I would say, okay, maybe we can, we want to reduce the CKD and other complications post-transplantation by improving them enough that they will have a best outcome. In a deceased donor transplantation, why would you do this? Because this is our best chance to get a transplantation and have a better outcome.
Yes, Sanjay, this is a big issue because the reduction of MEL score, of course, reduces the priority of patients, no? And actually, when we started using in Europe Terlipressin, we realized this issue, okay? In fact, the responders had a longer wait list than non-responders, okay, that underwent liver transplantation. And therefore, at least for Italy, for Spain, and even for France, there is a specific priority for patients with HRS-AKI. Therefore, the MEL score is frozen at the time of the diagnosis of HRS-AKI to maintain priority. Okay, and this is the way you try to treat the patients, and they maintain high priority on the waiting list. I know that this for US, where also the mean MEL score at which the patient receive a transplant is much higher than what occurs in Europe, may be an issue. But perhaps this may discuss in the internal policy also to identify whether a similar approach that is used in Europe may be approached even in US. That said, I want to say something because, you know, uh, when you use renal replacement therapy, you put 4 milligram DL of creatinine to compute the mass score. Okay. And you know, so thinking about, okay, if I'm using renal replacement therapy, I can give 4 milligram DL and maintain the patient with a very high score. I think that this is reasonable, that if the patient is receiving Terlipressin, it may be the same.
That's great. Thank you for that explanation. One additional question I have. Uh, we give albumin infusion or albumin replacement per with a large volume paracentesis, especially more than 5 liters of fluid that you are taking out. And there is a potential chance some of these patients do develop HRS-AKI with an LBP as well. Now, question is here: does POCUS may help determine the amount of albumin replacement in these patients to prevent this post-paracentesis circulatory dysfunction, that we can guide management based on that?
Yeah, Sanjay, I think that potentially it can, but we have no data for showing that. I mean, I was very impressed by the data from the Bern team. No, that actually most of the patients were doing large volume paracentesis and albumin, and they seemed all volume overloaded. But you know, in practice, these patients, nobody developed signs of volume overload except an increase in the risk of variceal bleeding, but were just 2 events. Okay, so potentially this can be done, but you know, you need a specific study designed comparing, you know, the changes in plasma renin concentration the day 0 versus day 7, and comparing the change in inferior vena cava, collapsibility index, and diameters. Potentially it can be, maybe, okay, but you need the data to prove that.
Thank you. Well, I'll let the forum now open for some question and answer. The Chandigarh group is here today, actually. I think Dr. Nipun Burma has been here, and anyone else from their group who has have published its results would like to share some experience and some questions or thoughts.
Well, thank you, Dr. Sanjay, and really enjoyed the talk by Dr. Salvatore. The question and some comments. So my question is, since we have the structural biomarkers as well as the functional biomarkers, do we have a classification today combining both the biomarkers as to which phenotype patients are likely to respond? So, say if you have urinary sodium, urinary osmolarity combined with, let's say, the NGAL, can we have an algorithm from your data set showing that which are the patients who are likely to respond so that we can actually prioritize the patients at the outset? And this is something. And second thing is regarding the POCUS. I think POCUS has really turned the table, and it is really helping in a long way because velocity time integral combined with IVC dynamics are actually more precise in, and they are more dynamic. So I think that is the future. And our group led by Professor Madhumita is we are developing some of the protocols for randomized trials. So I think that's the way forward. Thank you.
Thank you very much, Nipun. So regarding this question, the first question, so we, you know, when we try to evaluate the response, we actually proved that those patients that have an NGAL above 220 were less likely to respond. They all had low urinary sodium and high urinary osmolarity. Okay, we didn't check specifically if that predicted or not response, but for sure the biomarker of structural damage and NGAL in our case were actually able to identify a group of patients that is less likely to respond. Then how to take a clinical decision, okay, in these patients is still a matter of discussion, because I will still treat patients with vasoconstrictors and albumin if he meet the criteria of HRS, okay? But knowing that the likelihood of response is lower, and this may be a candidate for a randomized controlled trial, you know, if we want to explore a new strategy or to start start a preliminary discussion with, with our nephrologist to evaluate eventually this may be a candidate for renal replacement therapy. Let's start thinking if he is eligible or not. Okay. And yeah, regarding the comment of POCUS, I know very well your data. You are doing a great job with Madhumita in Chandigarh regarding POCUS and really are pushing the field. And I think it will be really important. If you are designing a randomized controlled trial, I'm very happy because that will provide convincing evidence that this should be applied in a clinical practice in a structured way.
Thank you. Thank you.
And
Thank you.
let's say then you need the training because you are very good in Chandigarh in doing that. Then most of the hepatologists that are the one carrying this patient will need a training about that.
Thank you. We also have the honor today, Dr. Stephen Caldwell, to have in our forum today. Dr. Caldwell, if you want to share your experience and thoughts and questions.
Good morning.
Good
I'm
morning.
still in my pajamas, so I won't turn my video on.
That's all right.
But thank you. I enjoyed the talk. I really appreciated just the plain, simple definition of hepatorenal syndrome that Dr. Piano offered. And I don't know, I don't have any experience with the ultrasound of the vena cava. I think it's reasonable to incorporate that. But I think, as was pointed out, training is probably necessary in how to use it. But it's a complicated area, and I really appreciated Dr. Piano's discussion and review. Thank you for asking me to comment. I thought I was in the background.
Thank you, Dr. Caldwell. We have this very interactive format. That's what I put like 30 minutes of Q&A, and I wanted to make it very open and have a nice discussion as well. Actually, EASL is having a POCUS session, so anyone who is interested to learn in hepatology and a POCUS should join that session. It will be very informative as well.
Maybe if you have a few minutes, or a minute or two to just discuss the specifics of how that's obtained, that would be interesting.
Yep. We might bring a session, a full POCUS session. Maybe we'll invite someone who can give a whole talk on the POCUS in hepatology.
Right.
That will be very nice. We'll definitely bring on someone who is doing, leading the way. Maybe the Chandigarh group we can bring in.
Thank you.
All right. Thank you very much. And maybe I can invite Dr. Prasoon Jalal now. Dr. Jalal, please.
This is great. Of course, Nipun is here, and I admire Madhumita for doing such a great work. Both me and Sanjay had our roots in Chandigarh as well. So with that context, I have little difficulty in this new definition. And especially, when you're putting the volume replacement in a bit of vague terms. My question is, POCUS, are you going to use it just one time to decide how much volume to give, or you want to use repeated measurement? Rather than chasing albumin, we should chase POCUS to decide how much volume you want to give.
Yeah, I mean, I have no definitive response according to, I can say what I'm doing, in clinical practice, okay? So usually for patients in whom I have a doubt that this may be volume overloaded, because that is usually the issue when you start the treatment. I'm not sure, perhaps these patients had a history of hypertension, potentially hypertrophic cardiopathy and so on. Therefore, in that case, we usually look at inferior vena cava before starting, plasma volume expansion. And in case there are signs of, volume overload, you may consider why that avoid, further expanding volume, and instead you perhaps consider using diuretics. But then for the assessment of response, the time after time, honestly, Sometimes we do if the patient is starting developing clinical signs of circulatory overload, just to confirm that. I know that in the protocol I show you from the Chandigarh group from Madhumita, they are doing every 24 hours or in case they need a further assessment. So I think that in future, if we validate that algorithm, it is likely that we will have, a sequential measure. So before the treatment, after, it may be 24 hours, it may be 12 hours, it may be adapted to the clinical scenario. For nowadays, I think it is hard to take a strong decision.
Yeah,
In particular, if you do not have strong training about doing that in a proper way, because I can tell you that if you are very expert, it is easy to take, a good diameter of inferior vena cava, but otherwise, if you are not trained in ultrasonography, it is easy that you are mismeasuring the inferior vena cava or collapsibility index, and the VTI is even more complex.
that is
Cardiac
very
VTI.
So how the holy grail is how do you define adequate volume replacement?
How we define adequate volume repair? Well, I can tell you what we are doing is that we are still doing the plasma volume expansion with albumin. Sometimes we do not use 1 gram per kilogram, 0.8 or 0.7 gram per kilogram is okay. And then we follow urine output and serum creatinine. That's it. If the patient is not responding and fulfill the criteria of HRS-AKI, we start Terlipressin. Then, if the patient is keeping receiving albumin because of Terlipressin, and if we have a central venous catheter, we prefer to measure central venous pressure. And if central venous pressure is above 12 centimeters of water, we usually continue just with vasoconstrictor without further replacing albumin. If it is above 15 centimeters of water, we even may combine diuretics, okay? But this is, I want to say, this is our practice. This is experience-based. We have no single randomized controlled trial, and therefore, but this is what we do.
That's great. It's a fascinating lecture. Really, you learned a lot. Thank you. That's great.
Thank you. Thank you.
Thank you, Prasoon. Anyone has any questions, please raise your hands or put in your chat box and we'll bring it to the forum. In the interval, I'm going to invite Dr. Dharmesh Kapoor, a very prominent hepatologist everyone knows, to give his insight.
So am I audible, Sanjay? I'm having some issues with the video.
Very well audible.
Right. So I think a wonderful talk, probably a whirlwind tour of what we know about this entity over the decades. And of course, I would still say that this is a work in progress. So we all say 1 gram per kilogram of albumin over how much time? And obviously, there were a lot of comments saying that you need to assess the volume, but you know that we assume that 20% albumin is going to draw at least 4 to 5 times the volume of the albumin administered into the intravascular compartment. But those studies were done in the non-inflamed milieu. So what happens when somebody has got the inflamed milieu of HRS? You also have an increased rate of transcapillary migration of albumin that you administer. So I think it all sounds very good, but at the end of the day, each patient has to be managed individually. So I don't think, just like you have in the general ICU practice, so there is no ICU doctrine which tells you that when you're starting noradrenaline for a patient with septic shock, you have to start with this dose. So should be the case in managing patients with HRS-AKI. Dr. Piano's point is well taken that in the last trial, which gave FDA approval to Terlipressin, probably the patients had received a lot of albumin even before the vasoconstrictors were started. But I don't think that can be the whole truth. So there is a general perception that when you use a very potent splanchnic vasoconstrictor in patients who already have a hugely dilated splanchnic circulation, there is a risk, even if you're not using albumin, of putting them through to volume overload. So I think every patient's management needs to be nuanced. There are many unanswered questions. I quite liked your question of the creatinine purgatory. But we also must realize that many of these patients have a recurrence of HRS-AKI the moment you stop the vasoconstrictor, and you treat them again with Terlipressin albumin cocktail, and they tend to get better. But again, this is a very wide field, and it has to be a nuanced care of every patient. Many years ago, I'd told Dr. Anjali that if you stop the patient's diuretic, that was the first treatment of HRS-AKI in the initial definition of this particular condition. But you know that there is also a cardiorenal angle in many patients who present with AKI. So though I do agree that initially you should be stopping the diuretics, but there are a good number of patients who we think are HRS-AKI, but they probably have a cardiorenal angle too. And that's something which we were overlooking because the cohort or phenotype of patients in yesteryear was completely different from what we see now. Dr. Piano himself said that we are seeing more and more of steatotic liver disease related complications, patients who probably have an underlying element of some kidney dysfunction. For want of a better word, I would not say chronic kidney dysfunction, but some dysfunction is already there at baseline. So you really do not know what would sway the balance in patients like this. So it's a very complex topic. Probably should not be, bogged down to trying to type patients or putting them in boxes. So those are my comments. Thank you.
No, Dr. Kapoor, you introduce a lot of important points. Okay, I agree that we should try to personalize, but on the other hand, we should also try to follow, some specific scheme and algorithm to, to manage these patients. But there are some points that I think that you say that are very important. One of them regarding, the inflammatory milieu. What I can say is to be very careful in patients that have AKI precipitated by pneumonia, because there are several studies, even those in which the French trial exploring the use of albumin in the non-SBP infections, that show that actually probably this have an increased permeability of the lung, favoring the transcapillary shift of albumin, and this may actually favor pulmonary edema. Okay, so personally, I'm very careful in a patients with cirrhosis, AKI, that have a pneumonia, okay, a lung infection. And yeah, you were also right stating that these patients now we see much more patients that have an underlying cardiopathy, not necessarily cirrhosis cardiomyopathy. And for sure, in the future, we will need to personalize a little bit more the management of these patients. And in that kind of patients, I think that that POCUS is the most important one.
Thank you both. Thank you, Dr. Kapoor. May I invite Dr. Benedict Maliakal from Nashville, Tennessee. Dr. Maliakal, please.
Thank you. That was a fantastic talk, but there are so many questions as is the case with most of topics. One question I have is, I don't think we have defined how much volume and what mean arterial pressure should be the ideal thing. I think if I were thinking about how to go about would be looking at the cardiac output, what happens to cardiac output by volume expansion and increasing the mean arterial pressure. If the cardiac output doesn't increase, then what we're doing is not going to work for HRS. So why don't we do longitudinal cardiac output as a way to decide how much mean arterial pressure should rise and how much volume should be given? Has anybody done any studies in that respect? That's one question. And the other question is, I think RRT in patients who are not transplant candidates, you know, nephrologists sometimes refuse to give renal replacement therapy. But I think in two situations, one is alcoholic hepatitis, and the other one is probably hepatitis B related acute on chronic renal failure with AKI. I think those two situations, at least a short-term trial of RRT should be considered because some of these people will recover without transplant. And the third and last one is probably a little controversial, the role of plasmapheresis in patients who don't respond quickly to volume expansion and terlipressin.
Okay, I started the third one. I'm not aware of a study supporting plasmapheresis in these patients. So this is not we were not doing that. I'm not aware of specific study in this field. So yeah. So regarding the second point, I fully agree. Okay, that kind of situation. I perfectly agree that our patients with acute correlated hepatitis or acute or flare of HBV, these are patients that they can actually show really an important improvement. Okay, so this is the kind of patient they are usually young, in which we push for doing a trial of renal replacement therapy, in spite that they cannot be currently as evaluated for the liver transplantation. And regarding the first point that was about cardiac output, role with pressure. So if we talk about plasma volume expansion, we are increasing plasma volume because we want to increase the cardiac output. Okay. So if we would have an accurate measure of cardiac output that is feasible, but it should be dynamic, it would be the grid. So in ICU, it is easier because you have an adequate monitoring of cardiac output and can be easily done. But in patients that are admitted in general ward, is not easy. You can try to do it with the VTI measurement, okay, but the data in patients with cirrhosis are really few, and those coming from RCU are controversial. There are some group that push using small volume evaluate the VTI. Other group they say okay, but that effects will last like 1 hour, and then you should repeat continually the ultrasound of the heart.
But
So
is there are there patients who you give volume expansion and terlipressin, and if their cardiac output doesn't improve, that should immediately show that those people will have poorer prognosis, and that's what.
No, actually not because so after the depressing, so the most of the patients experience a reduction in cardiac output, but this is related to the increase in peripheral resistance. So you may have an increase of mean arterial pressure because there is an increase in peripheral vascular resistance, and the cardiac output is actually reducing a little bit because there is and still the mean arterial pressure is increasing. Then when we talk about a definite threshold of mean arterial pressure to as a target, I have to say that while there is strong evidence that those that have an increase in mean arterial pressure have a better response to terlipressin and albumin, there is no study evaluating a fixed threshold that do not predict the response. So in my practice, when I use vasopressor, I'm happy. And so when we're using terlipressin, I'm happy if the mean arterial pressure is increasing, but I'm still not using that as a target, because otherwise, if you try to increase the mean arterial pressure on 10 millimeters of mercury, you will reach like 6-8 milligram per day of terlipressin, and the side effects are sure. Okay, sometimes you are less ambitious in terms of increasing mean arterial pressure, and still the patients start increasing diuresis and improving renal function.
Thank you.
You're welcome.
Thank you very much.
Sanjay, can I ask one more question?
Yes, absolutely. Please go.
The biggest challenge, the reason terlipressin is not being approved in many centers, we all know that it's a very useful drug, it works, is because the studies haven't shown improvement in survival or mortality or transplant-free survival. And if you look at the data, of course, we get it that if the creatinine is more than 5, it doesn't work. But the problem is, even if there is a reversal improvement with the HRS-AKI, then it recurs, it comes back, as Benedict mentioned. And so where do you think is the problem? Of course, you're not correcting the pathophysiology, but at the same time, what will be the ideal approach so that we can prevent the HRS-AKI from recurrence and also improve long-term survival? Because as I mentioned, that none of the studies, just like alcohol issue and steroid and alcohol hepatitis, so it's not showing any long-term improvement of the survival. With your expertise and in-depth knowledge, where do you think, where's the disconnect? How we can take it a little bit farther so that we can prevent recurrence, or there's any way we can improve the outcome?
Yeah, I think one of the way to reduce the recurrence, for example, what we do that is not in trial is if you get the response to, I don't know, 6 milligram per day of Terlipressin, or, we always try to reduce the infusion rate as to 4 milligram for one day, 2 milligram for another day, and then until stop, because we never stop immediately when a patient is receiving Terlipressin at 6 milligram or 8 milligram per day, because in our experience, this reduction would actually cause a rebound on serum creatinine. In fact, in intensive care, nobody is withdrawing norepinephrine suddenly. You're always decreasing the infusion rate until, and this is what we do with Terlipressin, although it is not stated in none of randomized controlled trial. But this is what we do, and this slightly reduce the risk of recurrence. Then there are still a group of patients that will recur anyway, and some patients that you will never be able to stop Terlipressin, okay? We defined several years ago, and for that patient, if transplant is an option, you try to prioritize. If transplant is not an option, you may consider the placement of tips, okay? Otherwise, they will stay in Terlipressin forever.
So in the tips context, do you think tips will work in patients with HRS-AKI?
It may work. It may work. The issue is that I will not be very comfortable to start treating a patient directly with tips. There is probably know that there is a randomized controlled trial ongoing in Germany, multicenter, exploring tips versus Terlipressin and albumin, and we expect the results in a couple of years, I guess. Considering the issue of cirrhotic cardiomyopathy, that all the study of tips in ascites have shown that those with high serum creatinine have worse outcome, I would be a little bit worried to use tips up front, But it may be a strategy to prevent recurrence.
Got it. Okay, great. Thank you.
Thank you.
Thank you.
One other question I have in my mind is, cirrhotic cardiomyopathy is quite prevalent in a pre-transplant populations. And in fact, in one of our studies recently, we submitted an abstract. We found at least two components of the, my cat is here. Two components of the cirrhotic cardiomyopathy was prevalent, almost 37% of the patients. So that with the high prevalence of this cirrhotic cardiomyopathy, I have a question from Dr. Soham Sharma here. How do we use Terlipressin? The potential risk of any pulmonary edema may be higher in this group of patients because of the non-compliant heart. Is it something that we should be vigilant about diagnosing cirrhotic cardiomyopathy more, especially these patients, vulnerable patients, those patients with HRS-AKI, before subjecting them to albumin?
Yeah, I mean, no, albumin would not be, a problem unless they have, severe diastolic dysfunction and you expect to cause volume overload, because actually, as I showed you, there is also an improvement in cardiac function, okay? Of course, you should be very careful. Regarding the Terlipressin issue, I think that we do not have a definitive conclusion that we can, you say, okay, these patients will never benefit from Terlipressin, I'm not using. What we know is that patients should be carefully monitored because his risk of developing, respiratory complication is higher. Then potentially in future, one may consider an alternative treatment. Maybe that a patient with cirrhotic cardiomyopathy may have more benefit from, another vasopressor that is also have a positive inotropic effect. Okay. I don't know if that patients maybe fit better with, norepinephrine instead of terlipressin. I don't know. Nobody knows, but this is something that may be explored. Dobutamine that was explored in this field in combination with terlipressin, it seems it doesn't work, but also because dobutamine has also a vasodilator's effects. Okay, but for sure it is possible that subgroup of patients may benefit from a different, pressors that have more inotropic effect. Sorry for my voice.
Thank you so much. I think I'm almost at the end of our meeting. Any other questions, a last minute question from anyone else? I'll give 5 seconds. Well, if not, Dr. Piano, thank you so much. This is a wonderful talk, and with your permission, we'll put in our website people who missed or people or attendees who wants to revise their and listen and learn more about this. They will come back. And thank you very much for giving your time and sharing all the knowledge that you already had experienced over a long time and with us. Thank you so much. Thank you very much. Thank you.
Thank you. Bye-bye, Sanjay. Bye, Nipu. See you. Bye-bye.
Bye-bye.